Thank you so much. So it's with great honor and pleasure to be invited. It's also with great reputation that I prepared this talk because I'm a transplant. I take care of these patients throughout transplant. I rarely get to make the decision on whether or not they should go to transplant. They are referred by my friend Dr. Nesvitsky or by Dr. Mark. And many times the decisions are already made. And then I get this title, early, late, non-ablative. Well, they get early when Dr. Nesvitsky thinks that they should be reversed early, and they come to me late when Dr. Nesvitsky thinks so. So now I had to do some independent thinking. Why do a transplant early? Why do a transplant late? I hope that at the end of this talk, how do I move this forward? Oh, back. I will have to convince you that one should still transplant early. The autologous transplant is a very important part and continues to be a very important part of the initial treatment for myeloma. And perhaps I'll give a little bit different arguments for it than the people that have preceded me. I will also talk briefly about allergenic transplantation because I was asked to do so, but also because I think that it continues to have a role and that it will have a bigger role as time goes on in this field. So without further ado, why transplant early? Why autologous transplant as first-line therapy? 3 arguments. I still believe it is the standard of treatment, and I think some of the slides that I will show you repeat what others have said here. I will make the argument that it's perhaps less toxic than many of the currently explored alternatives. And I will finally make the argument that let's not forget that there may be a fraction of these patients that are cured. And I think, at least when I go to meetings, that is often considered against the current dogma, but I do think accepting that is looking at the data the way they are and may open avenues for new treatments. So why is the standard? It has long been the standard. These are very old slides showing that comparing autologous transplant versus standard therapy, showing that progression-free survival with autologous transplant was considerably better, and that, sorry, these are 2 different studies, both studies showing that not only was progression-free survival better, but overall survival was better. And since then, an endless debate, an ever-changing debate, in part about what are the optimal conditioning for transplant, in part about what are the optimal age range for transplants, what are the optimal stem cell sources for transplants, what are the optimal maintenance treatment after transplant. All of that you hear about somewhat at meetings like this, although some of it disappears in transplant meetings. But the other arm is, what is the standard arm? Does this still apply with modern therapy? And with modern standard therapy, and I don't think we will ever have the answer. This debate will continue to go on as modern therapy, standard therapy continues to improve and we get 1 new drug a year. But that being said, from a very practical standpoint, all the randomized studies that have been done over the years, and these are some of the older ones, have consistently shown that transplant consolidation is at least as effective and in many cases adds about a year to remission duration on average compared to standard therapy. Overall survival in some studies is significantly better, in others it's the same. But I would ask then the question, if overall survival is the same, why not take the treatment that has the best event-free survival? That would be logical in any form of cancer treatment. Does this still hold in the modern era? And I apologize for the poor quality of these slides. You just saw them by Dr. Giralt in a better format, but it's the Palumbo study with relatively modern treatment, melphalan, prednisone, Revlimid, compared to MEL 200, 2 courses. And both arms were well matched or well balanced. You saw the same data looking at another aspect of these data, namely the maintenance with Revlimid or not, but there was also randomization between transplant or not. And what do you come to see? Again, overall survival is the same in both groups, perhaps 9% better, but not significantly yet, possibly because the follow-up is still limited. Many of these people are still early on, perhaps also because our salvage therapies are excellent. But that being said, one adds about a year of time without treatment by doing an autologous transplant, even in the modern era of Revlimid. So I believe this continues to support the fact that transplant should continue to be very effective. It should continue to be considered highly effective and part of the standard treatment. Now, that's an argument that never will end as we get carfilzomib and pomalidomide and modern ways of inducing remissions. A second argument is it's less toxic. Why is it less toxic? Because you get enormous periods that are on minimal treatment or on no treatment whatsoever, as opposed to conventional treatments that are quite prolonged and expose one to chronic taking of medications. Not always easy for our patients, being compliant, having neutropenia, having neuropathy. Is there data to support my argument? There's some of that. And this is some old data from 1989 showing that with an early transplant, the quality of life with this particular twist score was somewhat better with the myeloma, in myeloma treatment compared to late transplant. I could not find more recent data in myeloma. I do find treatment data in follicular lymphoma, where again patients undergoing transplant were compared with those not undergoing autologous transplant, and where for all criteria patients were compared, fatigue, nausea, pain, etc. The quality of life of transplanted patients was better than that of non-transplanted patients. Again, probably because there's many of these patients that we are now for years devoid of treatment and have years of treatment-free periods. So the argument that we would not do a transplant because it's too toxic really doesn't hold very well for me. Lastly, and to me perhaps the most important argument, is what I have seen now after years of treating such patients. Some of my patients are now 10 years out and have never needed treatment anymore. Is that an anecdote or is there reality to that? And I think Dr. Barloghy's group was the first one to show this. Cure of myeloma hyperreality already in 2005. They showed with their total therapy at that time, they compared patients with cytogenetic abnormality with patients without cytogenetic abnormality, and they saw this curve flatten out, at least for the ones without cytogenetic abnormalities, at about 20%. And so patients going out for more than 7 years rarely relapse. We are far from having any of those data with any of the newer therapies. So to abandon anything that has this demonstrated effect would be dangerous, I believe. Are they the only group showing that? No, they are not. There's also a Spanish group. This is from PITHEMA, where they compared patients having a CR to treatment with those with near CR, those with very good partial remission. And they showed again that those that had a CR had a plateau of the curve, at 10 years, 15 years, 20 years, and that is event-free survival that seemed to be stable. And in this publication that is more recent, they really mention that the relapse rate is low in patients who remain disease-free with more than 11 years of follow-up, possibly signifying a cure for patients in CR. So my argument, and I think this to me is the determining argument for continuing to offer this treatment up front. What if we lose that by delaying transplant until after relapse? What if patients' disease evolves? What if the clonality of, as most cancers do, diseases become more aggressive, and I think we are at risk of creating an experience of a less effective, more toxic transplant if we routinely offer it as a second line. Second part, and I don't know whether I'm running out of time, but what to do about this part of the curve, the patients who relapse early, the patients with very aggressive disease. Clearly, autologous transplant works, but it's far from 100% effective. What about allergenic transplantation? Why would allergenic transplant work? This is a slide from my good friend and former mentor, Dr. Trico, who showed years ago that donor lymphocyte infusions in patients relapsing after allotransplant can induce remissions. This is a serum monoclonal gammopathy curve. It goes up after the transplant. Patients get the donor peripheral blood cells, goes back in remission, and, but does get graft versus host disease. But this is proof of principle. Another argument for allotransplant is that we give a clean graft. And does a clean graft compared to an autologous graft work? These are data from the IBMTR showing that syngeneic transplants with a clean graft without graft versus lymphoma effects have clearly inferior relapse curves and superior progression-free survival, and actually perhaps superior survival with a p-value of 0.17. So clean graft, graft versus lymphoma effect, all arguments to do allotransplants in high-risk patients. How does it work out in reality? Myeloablative transplant, I'm not going to go into. It was done. It showed less disease recurrence. It was abandoned mostly in patients undergoing allotransplant because of excessive toxicity in patients with myeloma. People have focused for the last 10, 15 years on non-myeloablative transplant, and there are 6 randomized studies, most of them following this scheme. Patients get an induction treatment. This is the Nordic study. They get an induction treatment, get an autologous transplant, and then if they have a sibling, they get an allotransplant, or if they don't have a sibling, they get a second autologous transplant. What are these 6 studies? The HOVON, the Dutch, the Italians, the Americans, the Nordic and European group, the French, the Spanish. Now, the Spanish group had a little bit different study. Patients were transplanted only if they failed to get a near CR. So this is a restricted group with rather poor prognosis. And the French group is for patients with deletion 13 and with a high beta-2 microglobulin, again a restricted group. So I will focus on these 4 studies. These are the references. Some of them were recently updated. All of them use a very low intensive chemotherapy conditioning regimen. And notice that these are large numbers of patients. Very few of these patients typically have HLA identical siblings. And in each of these studies, in none of the studies is survival inferior with allotransplant. And in some studies, it's considerably superior. And I'll show you some curves here. These are the relapse rates in the Dutch study, donor versus no donor, the Italian study, and Nordic study. Relapse rates are every time considerably lower. Now, of course, they have more toxicity and more problems. How does that translate in overall survival? The Dutch study, no difference. The CTN study, no difference. The Italian study, a dramatic difference. And the European study, with increasing follow-up, more and more difference. So this has been twice updated, but at 8 years, there's a considerable difference in long-term outcome. So should we do an allo transplant for everybody? I don't believe so, but there may be certain groups, deletion 13q, where in the European study, patients without with an autologous had very poor outcome, and with an allo transplant had about a 40% long-term disease-free survival. In the Spanish study that I skipped, patients with a partial remission, less than a complete remission to the first transplant, a second autologous transplant versus an allo transplant, a considerable difference in progression-free survival. So I think there are ways to recognize the advanced patients. Of interest, and patients relapsing after an allo transplant. This is now the fate of patients who had an allo transplant or who had an autologous transplant, and then they relapse. In both procedures, there are a lot of relapses, but if one relapses after an allo transplant, then the survival post-allo transplant is superior to that of those who have undergone autologous transplant. What does this mean? This means probably that there's an ongoing GVL effect even after transplant. And we see that in many of the diseases we treat, patients relapse but seem to have a more indolent course, probably because of persistence of the graft. So one could think about this again as going back to this old Trico slide, where patients got donor peripheral blood cells. This is, after all, also a relapse. Perhaps we don't always have to give the donor peripheral blood cells. Perhaps we now give Revlimid, or perhaps we give pomalidomide, and we will have better results than we used to have before. And if we do this in a sophisticated manner, we may actually be able to get rid or to avoid this graft versus host disease effect. So I conclude that an allogeneic transplantation, I did not have time to talk about that, but the toxicity cannot be abolished, but it can be much reduced, including toxicity of graft versus host disease. One needs prolonged follow-up to see the benefit. It is particularly attractive for poor prognosis patients, those who don't have good responses, those with adverse cytogenetic abnormalities. I do think we have become much better at finding alternative donors, at avoiding graft versus host disease. I think we should incorporate this earlier, and we should incorporate maintenance strategies even in allotransplant, because allotransplant by itself is not sufficiently curative either. A couple of examples. Oh, this doesn't move anymore. Okay. So this is one case of a 35-year-old female with a deletion 17p, IgG myeloma. She had an autologous transplant. These are her IgGs. She had an autologous transplant, rapidly relapsed, and then we did a cord transplant. And as you see with the cord transplant, she had a better response than with anything before that. But it didn't last. And I would make the argument, and it was a very difficult experience for the patient, and she ended up not doing well in the long run. What if we had done this earlier? What if we had skipped the autologous transplant? Would we have been able to avoid this? This is another gentleman. He had a very complicated illness where he had the combination of essential thrombocytosis with a secondary chloroma. So he had really, for all practical purposes, an AML, and at the same time he had a multiple myeloma. We see this once in a while. And here, nobody thinks twice before offering him an allotransplant because he has leukemia. But keep in mind, by the time we added a little bit bortezomib to his treatment for his leukemia, by the time of the transplant, he was only in partial remission. But we used the transplant as initial. He was in complete remission of the acute leukemia. He was in a partial remission of the myeloma. After the transplant, he has gone and stayed in a complete remission of the myeloma, as well as the essential thrombocytosis and the acute leukemia. We are now more than a year out. He continues to do very well without any graft versus host disease. And so I think we should give thought to revisiting this issue of allotransplant, exploiting it maximally, and combining it with innovative therapies. That's easier said than done. Now, one issue that we have overcome in the last couple of years is the issue of unavailability of donors. We have ways, different institutions have identified ways of finding good donors for the large majority of patients. So my conclusions, autologous transplant remains the standard. It may have better quality of life. There may be a cure in a small fraction of patients, but that's something to be improved upon. And I think allogeneic transplantation should be considered in poor risk patients and should continue to be investigated. With that, thank you for your attention.